Hello everyone. Today we are going to discuss the anatomy of the scalp. In this session, we are going to discuss the layers of the scalp and its applied aspect. So let us begin the session. So in this slide, what you're seeing here, this is the scalp. So basically, the scalp is a soft tissue which is attached to the cranial vault. So this is the cranial vault, and the soft tissue which is attaching to the cranial vault is known as the scalp. Let us see the extent of the scalp. Anteriorly or in the front, the scalp is attached to the supraorbital margin. So this is the orbit. So above this, there is a margin which is called as supraorbital margin. Behind or posteriorly, the scalp is attached to external occipital protuberance. There is a protuberance on the occipital bone. It is external. That is why this is called as external occipital protuberance. On either side of this protuberance, there are two lines which are known as superior nuchal line. So this is the attachment of the scalp posteriorly. On either side, scalp is attached to the zygomatic arch. Now we will see the layers of the scalp. There is a mnemonic to remember the layers of the scalp. The spelling of the scalp is SCALP, and the starting letter of all the layers is the mnemonics to remember the layers of the scalp. So we will see the first layer, which is the skin. So this is the first layer, and the second layer is the connective tissue. The third layer is the aponeurotic layer or the epicranial aponeurosis. The fourth layer is the loose areolar tissue, and the fifth layer is the pericranium. So these are the layers of the scalp. We will discuss each layer in detail. So we are discussing the first layer of the scalp, which is the skin. The skin of the scalp, it is thick and it is hairy. Therefore, there are numerous sebaceous glands and the sweat gland. Since we have numerous sebaceous glands, we know that this is the sebaceous gland and this secretes sebum. The sebum via the sebaceous duct is poured out into the surface of the skin. Sometimes what happens is the sebaceous duct gets blocked. In such cases, the sebum produced by the sebaceous gland cannot enter outside and cannot exit outside, and therefore it accumulates within the sebaceous gland and produces a cystic swelling. This swelling is known as sebaceous cyst. Now moving on to the second layer, we have already discussed the skin, which is the first layer. This is the second layer, which is the connective tissue. So this connective tissue is a dense connective tissue. Numerous fibrous septa will pass into this second layer, and it will divide this layer into several compartments with fat in it. In this layer, there is blood vessels and nerves. If we take one compartment and see it in detail, so this is the fibrous septa, right? Now, we have the vessels inside. The vessels I am drawing now. The walls of these vessels are attached to the fibrous septa. Therefore, even on minute injury or the minor injury of the scalp, bleeding is very profuse, because under normal condition what happens, if a vessel is injured, it will retract and minimize the bleeding. But in case of scalp, as we already discussed, the walls of the vessel is attached to the fibrous septa and thereby it cannot retract, and that is why even minor injury of the scalp bleed profusely. So that was about the second layer, which is the dense connective tissue. So the reason for scalp injury bleed profusely is already been discussed. The third layer is the epicranial aponeurosis. It is also called galea. Galea in Latin means helmet. So the third layer is epicranial aponeurosis. As you are seeing, this is the epicranial aponeurosis. It is attached posteriorly to the external occipital protuberance and anteriorly to the root of the nose. there are two muscles which are attached to this epicranial aponeurosis, and this muscle on the whole is called as occipitofrontalis. So at the back we have occipital belly and in the front we have the frontal belly. Both the bellies are attached to the epicranial aponeurosis. So we will discuss the origin, insertion and nerve supply of both the bellies. So first we will discuss the occipital belly. As you can see, there are two bellies on either side posteriorly. They are called as the occipital belly. Now let us see its origin. As already discussed, this was the external occipital protuberance and this was the superior nuchal line. Our occipital belly arises from lateral 2/3 of the superior nuchal line. So this is the origin of the occipital belly and it is inserted to this epicranial aponeurosis. Now discussing about the frontal belly. This is the frontal belly. We have two frontal belly on either side. This frontal belly doesn't have any bony attachment. It takes its origin from the skin and subcutaneous tissue over the eyebrows and the root of the nose. So that is the origin of the frontal belly and it is attached to the epicranial aponeurosis. Having discussed the origin and insertion, we will now move on to the nerve supply of these two bellies. So you can see here, this nerve is the facial nerve which is the seventh cranial nerve. One of the branch of facial nerve is called as posterior auricular branch of the facial nerve will supply the occipital belly, and we have another branch which is the temporal branch of facial nerve which will supply the frontal belly. Now we will see the action of occipitofrontalis. First we will see the frontal belly. We already know that this is the frontalis muscle attachment. Now acting from above, what the frontal belly does is it raises the eyebrow as in case of a surprise. Now acting from below, it will produce transverse wrinkles on the forehead as in case of fright. When both the muscles act alternatively, the scalp will move front and back. That is, the scalp will move anteriorly and posteriorly. Now the applied aspect is in this epicranial aponeurosis. Now what happens? There is something called as gaping of scalp wound. Gaping means a wound that is widely open. Now what happens is, if there is any injury which is transversely oriented in the epicranial aponeurosis, such wound will gape, which means they are widely open. The wounds which are vertically in the epicranial aponeurosis, they will not gape because of the tension provided by the occipital belly of the occipitofrontalis on the epicranial aponeurosis, and thereby any wound which is vertical will not gape, but any wound which is transversely oriented in the epicranial aponeurosis, they will gape. You can see in this image, this is the gaping of the wound, which means it is widely open. Now we are moving on to the fourth layer, which is the loose connective tissue. It's also called as the subaponeurotic tissue. You can see here, this is the skin, this is the second layer connective tissue, this is the third layer of the aponeurosis, and this is our fourth layer, which is the loose areolar tissue. It is also called as subaponeurotic space because sub means below. It is below aponeurotic layer, that is why it is called subaponeurotic space. So we will be studying about this layer. So this is a potential space. It is beneath the aponeurotic layer and the pericranium. So it is a potential space. Okay. Now we will see what are the clinical implications and contents of this space. Now one of the content of the space is emissary veins. These are valveless. These veins, they connect the valves in the scalp which are extracranial because they are outside the cranium. They are called as extracranial. They connect extracranial veins with intracranial veins. They inside the cranium, that is why they are called as intracranial veins. So the emissary veins will connect the extracranial veins with the intracranial veins. Therefore, any infection or thrombosis in this layer, what happens is they travel via the emissary veins into the intracranial veins. Thereby, they can be fatal. That is why this layer of the scalp, the subaponeurotic space, is called as dangerous area of the scalp. Now, there's one applied aspect here, that is the black eye. Now, what happens is, as we already discussed, subaponeurotic space is a space in between the epicranial aponeurosis and the pericranium. So, we will see what happens. Now, so this is the subaponeurotic space here, that is beneath the aponeurotic, the epicranial aponeurosis with the frontalis and the occipitalis, and this is the pericranium, which is the fifth layer of the scalp. So this is the potential space here, which is called as subaponeurotic space. Any blood collected in this layer will gravitate, or it will trickle downwards. We know that the frontalis muscle doesn't have any bony attachment. Therefore, the blood trickles down and it gets accumulated around the eyelid, producing a condition which is known as black eye. We have one more clinical condition here, which is known as safety valve hematoma. Let us see what is that. We already discussed that this is the epicranial aponeurosis and this is the pericranium. Now this is the skull bone. Beneath that we have dura mater, which is the meningeal layer. Now if there is any fracture of the skull and if there is any tear in the dura mater and the pericranium, what happens is the bleeding, the blood first passes into this subaponeurotic space. It will completely fill up this space. Only when the space is completed, the blood will start accumulating inside the cranial cavity. Therefore, there is some time given for medical, there is some time given so that for the medical attention. If the space was not there, what would have happened is the blood would have accumulated within the cranial cavity and thereby compression of the cerebrum would have occurred. So that is the function of this subaponeurotic space. That is why it is called as safety valve hematoma. Now next we are moving on to the last layer, which is the pericranium. So this is the pericranium what we are seeing here. This pericranium is loosely attached to the bone except at the sutures. At the sutures, the pericranium is tightly attached to the bone. So what happens if there is any fluid or blood collection beneath the pericranium? The swelling will take the shape of the concerned bone. Now we will say a condition that is called as cephalohematoma. So what is that? As already discussed, any hemorrhage or blood collected beneath the pericranium will take the shape of the bone, and this is known as cephalohematoma. Now we are seeing something called as caput succedaneum. Now this caput succedaneum, it is a temporary condition. What happens when a baby passes through as a normal delivery? So what happens when it passes through the birth canal? Because of the pressure with the vaginal canal on the head of the fetus, there will be interference with the venous return. So what happens is a temporary swelling occurs and this will subside itself. That is known as caput succedaneum. We have something called as subgaleal hemorrhage, which is nothing but blood collected in the subaponeurotic space. Next we have cephalohematoma. We already discussed beneath the periosteum. If there is any collection of the blood, it will take the shape of the concerned bone. So this was about the layers of the scalp along with the applied aspect. In next session, we will be discussing the nerve supply and the blood supply of the scalp. Thank you so much for watching this video.